I will be recording this webinar today, and it will be housed on the Alzheimer's Society of Toronto's YouTube channel, and it may also be posted onto Alz Educate as well under recordings for family care partners. A little bit of housekeeping. Everyone has been muted, but if you do have questions for our presenter today, you can either put it into the chat or the Q&A section, and we will definitely try to get to as many as we can before the session ends. This webinar is slated to end at 12 p.m. So without further ado, I would like to introduce our speaker today, who is Marilyn White-Campbell. Marilyn White-Campbell is a clinical geriatric addiction specialist with Baycrest Long-Term Care Behavioral Support Outreach Teams. She is the provincial lead for Behavioral Support's Ontario Brain Change Older Adult Substance Use Collaborative and has recently launched Cannabis and Older Adults, Know the Facts. Marilyn is a co-investigator with Canadian Coalition for Seniors Mental Health Project, which established 4 national clinical best practice guidelines for substance use disorders in older adults, including alcohol, benzodiazepines, cannabis, and opiates, and is co-chair for the Alcohol Working Group. She's the recipient of the Ontario Psychogeriatric Award of Excellence and recipient of the inaugural Seniors Mental Health Outstanding Care and Integrative Practice Award from the Canadian Academy of Geriatric Psychiatry / Canadian Coalition for Seniors Mental Health. With over 35 years of clinical experience working with adults and substance use disorders, she is recognized as a pioneer in the field of geriatric addictions. She is teach trained through the Faculty of Medicine at University of Toronto in tobacco education and is a strong advocate to support smoking cessation among older adults in long-term care. So please join me in welcoming Marilyn.
Good morning, everyone. Thank you for coming today. Thank you for your interest in this topic. So I'll talk about alcohol use disorder and alcohol use dependence in older adults with a focus on dementia. So we're going to talk a little bit about the neurobiology of addiction, and how persons with a dementia respond to substance use. And I want to specifically talk about withdrawal because that's an important part, how withdrawal from substance and how to support a managed approach for substance use in a person with behavioral and psychological symptoms of dementia. And we want to look at some transitions to care by supporting or tapering the alcohol use or stopping the substance altogether. So I want to ask you a few questions if you could put in the chat box, and Julie, if you could read them out to me, the answers. So what are the highest attributable healthcare costs due to substance use in Canada? Is it opiates, alcohol, tobacco, benzodiazepines, heroin?
Looks like I'm seeing alcohol is what's predominantly coming through. A few votes for opioid and tobacco, but majority is saying alcohol.
Okay. So alcohol is the most commonly used substance in Canada, and there are about 3.3 million Canadians that consumed enough alcohol to be at risk for immediate injury. So those of you who chose alcohol, and we know that, so you're right, although tobacco does have a considerable healthcare costs as well. And about 4.3 million Canadians consumed enough to be at risk for long-term health effects such as liver damage. So if you see here, this is the substance attributable healthcare costs in terms of inpatient hospitalizations per capita in Canada for 2020. So you see here that the older adult has the highest per capita healthcare costs for substance use. So, and why are we concerned about alcohol? Because alcohol, as you've probably heard in the news lately, because of the new guidance around health guidance around alcohol, we know that alcohol is a level 1 carcinogen. So we're at the same stage as we are many years ago when tobacco was identified as a carcinogen, and there was a huge outcry about the use of tobacco and how it was causing cancer in people. And now we know that that there's sufficient evidence from World Health Organization, from research, to support that alcohol is carcinogenic and can be harmful to your health. And so that's why the new guidance came out around how to make informed decisions about your alcohol use. This is a little video that maybe you want to check on that later on, about the need for warning labels on alcohol, and how people need to be informed about the alcohol content, the amount of alcohol, the amount of alcohol in the beverage, and what are the health effects of alcohol-based beverage. We don't have that in Canada. There are some countries that do that, label warnings, just the same way as we have on our cigarettes. There's all kinds of cancer warnings on cigarettes, and there's pictures of, tongue cancer, lung cancer, and so on. But we don't have that on our alcohol-based beverage. They do have that in Australia, New Zealand, and I believe in some parts of the UK. But we certainly want to make sure that people are aware of the harms of alcohol. So I have another question. One of the things that happened during the pandemic was that liquor stores and beer stores were open, and they were considered essential services during the COVID-19 emergency. Why do you think that was? If you can type your answers in the chat box.
So I'm seeing withdrawal being one of the answers.
Mm-hmm.
Addiction.
Addiction.
And then the impact on the healthcare system. So risk of death is what we're also mentioning.
Okay. Well, yes, you're exactly right. And that was the thing, is that when people go into withdrawal, and they have a complicated withdrawal, then they may need medically supported withdrawal services. So this was enacted to keep people out of the emergency departments. So you couldn't get toilet paper in the grocery stores, but you could buy alcohol. Seemed counterintuitive, but the rationale behind that was because the government didn't want people going into withdrawal and then ending up in the emergency departments when the healthcare system was already so overburdened. Are there any other comments there, Julie, in the chat box?
Nope, not that I'm seeing.
Okay. So why is this different, addictions different in the geriatric population? So for older adults, the patients in alcohol withdrawal have more than twice the length of hospital stay than other non-admitted admitted patients, and they have higher complication rates. And they have, the older adult especially, have more prolonged and severe withdrawal than younger patients. And there are psychiatric consequences of alcohol use in the elderly, and particularly because elderly are more likely to be on medications. So there's drug-drug interactions. And for the older adult, and you'll hear me say this throughout the presentation, there's more of a risk for developing complications such as delirium. And we also know that older adults are more vulnerable to the effects of alcohol than younger people. So there's a lower tolerance, and older adults are highly impacted by alcohol because there's an increased frequency of disease and use of medications. And there's also differences in how older adults metabolize alcohol. So it takes a lot less alcohol to cause the same problems in an older adult than it would be for a younger person. So if a younger person drinks 3 standard drinks, then an older adult drank the same amount, it would have a doubling effect. Or if you look at it in the context of intoxication, it would take half the same amount for the older adult to have a blood alcohol level drinking 1.5 drinks compared to a younger person drinking 3 standard drinks. So the liver and the kidneys do not metabolize at the same rate as younger people, and so alcohol absorption is impacted, and it makes it that more complicated for older adults. So, so the criterion marking heavy drinking is a lot more stringent than for younger people, and even the screenings. Binge drinking is something that you want to be concerned about, because binge drinking without exceeding weekly heavy drinking limits is really common in this population. So again, because older adults metabolize at a different rate, slower rate, they can become more intoxicated and have more problems. So there are also older adults are at a greater risk for falls and for delirium. There's a higher rate of a predictor of a risk for suicide in older adults. It's a predictor of suicide risk. It is linked to cancer, liver disease, stroke, cardiovascular disease. And again, these are all the things that we're seeing now in the new health guidance on alcohol. And we see that there is I believe it's a 345% increase in the risk of gastrointestinal cancers, pancreas, liver cancers in the population if you exceed more than I think it's 7 or 8 standard drinks per day. So heavy drinkers are, it predicts risk, the highest risk for cancers. So we know that globally, alcohol is linked to over 3 million deaths per year, which is slightly more than lung cancer, and it certainly is higher than HIV/AIDS combined. And the proportion of substance use disorders in long-term care ranges from 23% to 45%, and it's higher in veteran settings. So what are some of the causes of addictions? Some people, believe that it's all genetics. If you have a first generation or second generation relative that first generation relative that had alcohol use disorder, then you will get it. But there are other factors. Age of onset of drinking, for instance, is a predictor. But there's also the belief that it's about a person's lack of willpower. It's a personal choice. So there's a lot of moralizing around alcohol use disorder. There are social environmental causes, and there are other theories on that it's a disorder of the brain. We know that there is some well-supported scientific evidence that shows that addiction to alcohol or drugs is a chronic brain disease that has the potential for recurrence and recovery. So in order to understand addiction in older adults, we need to look at the impact of substance on the brain. So, so the addiction is a chronic disease of the brain where the reward, motivation, memory, and related circuitry are affected. So these dysfunction in these circuits lead to the characteristic biological, psychological, social, and spiritual manifestations of a substance use disorder. So if it's reflected in individual pathology, pursuing rewards or relief by substance use, so people using it for relief from emotional pain or physical pain or other behaviors. And we look at addiction as characterized by the inability to consistently abstain, impairment in behavioral control, craving, diminished recognition of significant problems with one's behaviors and interpersonal relationships, and a dysfunctional emotional response. Like other chronic diseases, addiction involves cycles of relapse and remission. And without treatment or engagement in recovery activities, addiction is progressive and can result in disability or premature death. And one of the reasons that we see the high hospitalization rates for older adults compared to the younger population is due to the chronicity of the substance use. So if you've been using alcohol heavily, or even for some people moderately, but regularly throughout your life, that's where we're seeing the cancers showing up in later life. That's where we're seeing people having cirrhosis, having other cancers, pancreatitis, having esophageal cancers, breast cancers in women, those sorts of cancers. We're seeing that in later life. And people generally towards the end of life are ending up in hospital because of these health-related and substance-related issues. So if you take a look at this picture of the brain, right in the center is the center where pleasure takes place when a person uses a substance. So there's reward when somebody takes a substance such as alcohol, heroin, cocaine, tobacco, any of those things. And once the substance sort of gets ingrained into the brain, into that area of the brain that's responsible for that euphoria feeling, the brain, people tend to develop, because of that euphoria, the reward, the motivation, it soon becomes a compulsion, and people perseverate on it and then become addicted. So there is some evidence to show that there is a neurobiological basis to addiction, and we know that it is treatable, and again, it is a chronic relapsing condition. And I want to really point out that, again, when we talk about addiction, and there is a lot of moralizing around addiction, and unlike any other disease, if you had diabetes, if you have heart disease, if you have high cholesterol, in no other disease do people get turned away from being treated because of a health, of a lifestyle choice. So someone who has diabetes, that is, that's eating, let's say they're eating too much sugar, they're eating too many Tim Horton donuts, the doctor would never say, I'm sorry, I'm taking away your insulin, or I'm not going to prescribe you insulin. Or the heart doctor that says, here's your heart medication, but if you start eating chicken wings or, high cholesterol foods, I'm going to have to think twice. So there is a lot of moralizing around addiction. There's often the onus on the person to make changes in their substance use. And again, if you look at this model of the neurobiology behind addiction, that reward pathway and how easily it becomes ingrained into the brain, and that behavior gets repeated time and time again because it is so reinforcing. And the game changer now is that there are medications to help with alcohol use disorder and cravings for alcohol that are very effective, and we will talk about that. So I want to talk and ask you all about the low risk drinking guidelines, because we had from the Canadian Centre on Substance Use in the last 2 or 3 months, 4 months now, and they talked about health guidance. So now there are still low risk drinking guidelines, but does this mean anything? So how much alcohol is considered low risk for older males? 3 to 4 standard drinks for men, 2 to 3 for standard drinks for men, or 1 standard drink for men, or none. And how many is considered low risk for women? 2 to 3, 1 to 2, or 1, or none. So can you just type your answers in the chat box there? So this is for the general population, not for older adults.
So I see men 2 to 3, women 1.
Okay. So these guidelines that were issued by the Canadian Substance Center for Substance Abuse, the 2 to 3 standard drinks for men and 1 to 2 for women. However, now with the new health guidance, it's a continuum of risk. So if you drink more than 1 standard drink per week, then your risk goes up by drink. So so really, it's up to individuals to make their own choices, but one to 2 per week now is the guidance in terms of eliminating risk. So there's no risk by drinking 1 to 2 standard drinks a day, and then your risk goes up exponentially with the number of drinks. So, but I think that there is still some room for having low risk drinking guidelines to give guidance to people who already are drinkers and are not planning to stop. So in terms of the low risk drinking guidelines for older adults, in our new Canadian guidelines, we recommend that for women 65 years or older, no more than 1 standard drink per day with no more than 5 per week. So that's 1 per day and 2 non-drinking days. So, and for men, we recommend no more than 1 to 2 standard drinks per day with no more than 7 per week in total. And we recommend non-drinking days every week. So, and here's the proviso. And that's the thing, the messaging that should come across as healthcare providers, to have discussions with older adults, and for older adults themselves to know that depending on health, frailty, and medication, some older adults should transition to these levels even before age 65. So if you've got health issues, you've got heart issues, you're diabetic, you have cholesterol issues, all these things, you're on medications, multiple medications, then those are some of the indicators of frailty, and that's where people should be looking at transitioning and cutting down to these low risk drinking guidelines even earlier than age 65. And again, overall, as general health declines and frailty increases, alcohol should be further reduced to 1 drink per day or less on fewer occasions, with consideration given to drinking no alcohol. And those guidelines, again, evidence-based, and we looked at, again, older adults' metabolism and how alcohol impacts the body in later life. And so the evidence for this, although there's not a lot out there, the strength of this recommendation is still very, very strong. So now we want to move on to the dementia piece, and how, if you're going to work with somebody, how do you get somebody to engage in treatment if they don't, to work with somebody if they don't admit that they have a problem? And there's 2 pictures here. The one fellow says, "Please help me." That's easy, if the person is already willing and able and wanting some help, it's easy to help that person. But it's the person who doesn't admit that they have a problem and they still need help. And if they don't recognize that they have a problem, there's still ways that we can support them. So I always sort of think about some of the language that we have in the addictions field around people, around treatment approaches. And there's a lot of focus on motivation to change. But you can't ask somebody with a dementia to make that have that motivation to change if they don't admit that they have a problem, and they don't understand and appreciate and remember that they've got to change for what reason. So I'll talk a little bit about the management of alcohol. So what are the consequences for an older adult? Again, if they've been drinking very heavily, you're going to see that they will have, in terms of the central nervous system, there'll be sedation. They may have balance problems or ataxia. And if you drink even more, you might lose consciousness. A long-term effect of using too much alcohol is that people can develop neuropathy, so it will affect their balance, and they can become very ataxic and have falls. For somebody who has been drinking heavily and then all of a sudden they stop, the withdrawal seizures can occur, and that can happen within a 4 to 5 day window, and you can get the delirium tremens after day 2. So after the first day of stopping drinking, the alcohol withdrawal sets in within the first 48 hours. Certainly, it can affect the heart, lung dysfunction. It can cause cardiomyopathy. People can end up with aspiration pneumonia, again, as if they vomit, if they're by themselves, if they vomit and they aspirate. And certainly there's the risk for liver dysfunction and cirrhosis in later life. This is something that, again, for older adults with chronic alcohol use and repeated withdrawals. So there is a kindling effect of withdrawal on the person. So that's increasing severity withdrawal following repeated withdrawal episodes. So people can have an increased risk of seizures on withdrawal with each increasing number of withdrawal episodes. And again, it does affect the brain each time that they have these complicated withdrawals, and it can lead to permanent brain damage or dementia. And there is a need to treat with prompt treatment with benzodiazepines to prevent seizures and to prevent further damage, and that's done through thiamine, which is an over-the-counter vitamin that you can get. But there are neurological complications and serious ones, and it happens more often in older adults than in the general population. Again, one of the reasons is that people, with the chronicity of the use of alcohol. So this is a picture of somebody who would have Wernicke-Korsakoff syndrome. So they may have a loss of reflexes, they're emaciated, and numbness to the hands and feet, etc. So the memory is affected, confusion. There can be, lots of complications, cardiac complications. So we know that thiamine deficiency plays a great role in Wernicke-Korsakoff syndrome. And usually when people end up in the hospital, if they have not been eating and they've been drinking, and then they go through withdrawal, it's really important that the person has access in the emergency department, and they will normally, the protocol is for the person to receive thiamine. So it's because of, especially in the context of poor nutrition. You want to manage the diet very aggressively, and I've seen time and time again that older adults, if they get prompt treatment, they have changes in their diet. They've had the thiamine to continue to take medications, and you get good medical treatment. Then a lot of these things can, in some instances, be reversible. So we know that the Wernicke's encephalopathy is readily reversible if treated with adequate doses of thiamine within the first 48 hours to 78 hours of the onset of symptoms. And if it's not treated appropriately, it progressively results in Korsakoff syndrome and can lead to death in up to 20% of the cases. So we know that impairment can extend up to 30 years before the Korsakoff syndrome is noted. And there's not a lot of guidance, and there's not a lot of clear consensus on how to support. But we know that diet and thiamine and are important ways to manage. We know that in the hospital setting, that usually people, when they go into the emergency department, they need an IV injection or an IM injection or IV for 3 days, and then on a daily basis to take 100 milligrams orally. The one thing, and I hope that if there's any take-home message here, that in contrast to other causes of dementia, it's been suggested that the decline in cognitive or physical functioning in alcohol-related dementia is relatively non-progressive in abstinent drinkers. So, and even partially reversible, and that's supported by imaging studies. So somebody who has Alzheimer's, the trajectory is really, I don't know if you can see my picture there in the corner, but it's, there's a downward slope. But with someone with an alcohol-related dementia, it's pretty steady, and they don't generally get worse as long as they are abstinent and have good nutrition, etc. So I'm going to move quickly into the alcohol and tapering. But first, I want you to know that it's important to know how much the person is drinking and what's in a standard drink. So we talked about how many standard drinks is a safe amount. We now know that there's really not a safe amount, but if people do drink a standard drink, this is what it means. So one beer, which is 341 milliliters or 12 ounces of beer, that's at 5% alcohol, is the same. So across here, the cider, which is 341 mils or 5% alcohol, or 5 ounces of wine, 142 mils, or 1.5 ounces of alcohol. So rye, gin, rum, vodka, any of the spirits, or 43 milliliters mils, or 1.5 ounces of alcohol. So these are all the same. So when somebody says, I just drink beer, I don't touch the hard stuff, one beer is the same as 1.5 ounces of alcohol. Or I just drink wine, I never touch beer, I never touch wine. They're all the same. It's one standard drink. And when you're asking someone about how much they drink, it's important to know how many standard drinks they're drinking in a day, because that will determine what your course of treatment would be if you're going to do a taper. So a bottle, this is something really I use, to keep this at the top of my head all the time. So 26 ounces, so a bottle of hard liquor is equivalent to 17 standard drinks. Or a Mickey, which is 13 ounces, is about 8 standard drinks. And a bottle of wine has about 5 standard drinks in it. And again, a beer or a can of beer is 1 standard drink. A pint of beer is 1.5 drinks. A tall can. That's one thing, is always ask if you're a healthcare provider and people say, well, I just have 1 beer, or I have 1 beer, but always ask about how the size, because now we're seeing these, party in a can, these large cans that are, 1,400 mils of beer that they sell in Quebec, for instance, or in the United States. We're seeing more and more of the larger tall boy cans. And also there's higher concentration of alcohol in certain beers. There's strong beers that are at 7.2% alcohol. And then there is also beer that is at 10% and 11% alcohol. So it's important to know the drinking equivalents and know the alcohol content so that you can sort of get an idea of what the standard drinks are. there's a question in the oh, good point. So somebody has put a question and it says, according to the latest research, drinking wine to help with heart disease is counterintuitive. That's exactly right. So the reason that research came about was they said, well, there's antioxidants in grapes and that's healthy for you. But the alcohol and the carcinogenic effect of the alcohol cancels out the benefits of those antioxidants. So no, drinking red wine is not good for the heart, never was and never will be. So, so in terms of reducing alcohol use, so especially for older adults with dementia, you don't want to stop cold turkey. We don't want to precipitate withdrawal. There are some people that can manage abstinence without any consequences, but you have to be sure, pardon me, that there's a clear and recent history of abstinence without any withdrawal. So you need to know that the person has been able to stop and there's no significant problems. And also there needs to be a clear contingency plan if withdrawal were to emerge within 24 to 124 hours after stopping drinking. And so part of the protocol for somebody, again, who's cognitively intact would be to reduce the drinking until you're down to below 5 standard drinks, and that at a quantity where cessation has not led to problems in the last 3 months. So it's pretty complicated. It's not easy. Again, if you are caring for somebody, or the person has some health issues on top of their alcohol use, it can be really tricky to follow this, to follow this reduction in guidance. So you want to make sure that it takes place over days and weeks, depending on how much you're drinking. So it's not something that happens overnight. And for the general population of older adults with no health issues, no dementia, etc., you reduce by 1 standard drink every 3 to 5 days, and that's a fast taper. And if the person is finding it too difficult, if it's too hard, then you reduce 1 standard drink every 1 to 2 weeks. And again, that takes a bit of planning, because you got to set some goals around how much alcohol is to be purchased per week, and you have to standardize it. You've got to break it down into drinks per day. And again, if the person stops too quickly, it can exacerbate thiamine deficiency. And so you always want to assume that Wernicke-Korsakoff is a risk, and reduce and prevent thiamine deficiency, regardless whether or not reduction in abstinence outcomes are reached. So it's always a good idea for the person to be using thiamine. So in terms of the dementia in older adults, again, if you asked an older adult with dementia, send them home with these recommendations: reduce by 1 standard drink per week. If that's too hard, then do 3 to 5 days, and then if that's too hard, then 1 standard drink per week. How are they going to be able to remember that? So we're asking people with dementia to make some changes, but they can't remember what they're being asked for. So we don't expect them to admit that they have a problem, and or even to be motivated to make the change. But in some instances, the change needs to be made because the health and the mental health and the physical health, cognition is declining, and it's now at the time where applications to long-term care have been made, and you're going to be met with refusals to admit for the person that's using alcohol on a daily basis in a harmful fashion. So we want to make sure that with someone who has cognitive impairment, you don't initiate withdrawal without medical supervision. If there is no history of complicated withdrawal, the primary care can monitor. You can, so the family doctor can support, and a weekly taper can be done really slowly with no more than 10% of the person's intake or around one standard drink per week, and sometimes two. Sometimes you need to go slower, and 2 weeks is also considered good. And you want to monitor what's happening. Are there behaviors around the reduced amounts? Are you going too fast, or are you going at the right speed? If you're seeing the person is feeling uncomfortable, they're agitated, then you need to maybe employ some other approaches. So you can certainly redirect, and you can offer other non-alcohol based beverages. And you can use dealcoholized beverages, but you want to be very, very cautious. You don't just say, well, dad is drinking 10 beers a day, we're just going to switch them all out for dealcoholized beer. No, because you're going to put dad into withdrawal. So it's not to be used unless the person is already withdrawn from alcohol or as part of a slow taper from alcohol. So I put these on. I have no vested interest. I don't own any interest in any of these companies whatsoever. I just pulled them from the internet, but there is an amazing amount of no alcohol based beverage out on the market now that tastes surprisingly like the real deal. And I have to tell you, I've actually tried the Corona. It's called Corona, I think, Soul, and it has vitamin D in it, so they're promoting it as a healthy beverage. There is 0 alcohol in it. It comes with the same branding as regular Corona beer. I know that Stella Artois has the exact same green bottle and the same branding as the regular Stella Artois. It has 0 alcohol in it. And so for someone who is cognitively impaired, they unless they're somebody who religiously reads the labels, it's actually hard to see on the bottom of the bottle, but it says 0% alcohol content. And surprisingly, again, I've tried the Stella Artois, and it tastes just as bad to me as the regular Stella Artois. So it's 0% alcohol, and you can one of the ways that we've worked with older adults with dementia that are looking to transition to long-term care is to switch out when you take away one regular alcohol beverage every 2 weeks, then you substitute it with a dealcoholized beverage. With the beer, it's pretty easy. It's pretty straightforward. So if the person drinks Stella Artois and there's 12 bottles of Stella in the fridge, then every 2 weeks you swap one out for a dealcoholized. It's a little trickier for the alcohol-based beverages, the spirits, because you need to mix them, and the same with wine. But you would want to use the same bottle that the person, again, if it's someone with dementia, and we don't want to put them into withdrawal by stopping them quickly from alcohol, and you have the time, you're waiting for long-term care. We know that there are long waiting lists for long-term care. It can be sometimes 2 to 3 years. If you have somebody who's drinking 10 standard drinks in 10 to 15 standard drinks, and you swap them out one every 2 weeks, then it might take you 3 to 4 months to get them down to 0. And with the spirits, I have a family that has actually takes each week takes 1.5 ounces out of the bottle, the bottle, and puts in 1.5 ounces of the alcohol based beverage here. So this one here, that's called Liar's Spirits, and that one, it has a good flavor, and again, it's we want to give them sort of the autonomy to have a pleasant experience. And these beverages, because they taste the same, without the buzz, the person is being allowed to have their regular beverage. With the wine, again, 1 glass of wine removed from the bottle, and then adding some of the dealcoholized wines. And again, spending a lot of time on this, but because I've been so excited by this whole sober curious movement. There are so many brands out there, and they're actually made by the wineries, and they're made by the brewers and distillers, and it's not any cheaper than regular alcohol, because there is a big process to take the alcohol out of the liquid. So it's not any cheaper. So it might cost the same as it would, like, I think these ones here are the spirits are about $32 for 26 ounces, but you would pay that in alcohol, if you bought Canadian Club, or any kind of the cheaper whiskeys. So the wines, again, are made in the wineries, a lot of them in Europe. The wine sales for the wine sales for Spain, this is the sort of fastest growing products in Spain. People are really jumping on the bandwagon because they taste very, very good. So I encourage you to try them. So again, if you can switch out a dealcoholized beverage once every 1 to 2 weeks, that's a really slow taper. But how do you know that the person's going through withdrawal? What does that look like? So the person may have the sweats, the shakes, vomiting, diarrhea, irritability, a headache, and if they've been left too long without something, then they could have a seizure, and that's really the risky part of it. The other is hallucinations. So if any of those high risk things are happening, so seizures, the person's blood pressure spikes, or they have hallucinations or delirium, then they need to be in a hospital right away. And I have the CWA tool, I think, on the next page. There are some medications for withdrawal, but they're not the same as anti-craving medications. We'll talk about that in the next session. Some people will need diazepam, so Valium or lorazepam, to manage the withdrawal, and some doctors will use Librium. So again, if a person is really in severe withdrawal, then they need to be seen in a hospital setting. Sometimes family docs can manage it at home, but not when it gets to that stage. So in terms of for older adults, if they're going to long-term care, it's really, really important. Again, the application is in, and you need to know and establish that level of dependency. So how many standard drinks do they have in a day? And I always like to ask open-ended questions instead of do you drink? Because if I ask you, do you drink? It's going to be yes or no. And if somebody's defensive about that, they're going to say no. So I say, what do you like to drink? And establishing the alcohol intake. So for instance, what do you like to drink? Oh, I actually like a little bit of brandy, but I only take it at nighttime to help me sleep. The doctor told me it's okay to have a little bit of brandy when I go to bed. And so how much brandy do you have? Well, I have, I just have a glass beside my bed, and I have, just a little bit of in the glass. Well, can you show me the glass? Well, I don't know if you can see. No, you can't, because I've got a background thing there. But if somebody has, an 8-ounce glass and they fill it half full, then you know that you're dealing with more than one standard drink. So again, be creative in your questions, make sure that you're getting the right information. If you're not getting the right information and you still suspect that there's, a lot more drinking going on than the person is disclosing, then you want to ask the family collaterals, what happens? Asking the person what happens if you stop drinking. If they say, oh, nothing happens, but family members say, oh yeah, if they stop drinking, they're really cranky, they vomit, etc. And again, you want to look for some of those risks: vomiting, delirium, hallucinations, and seizures. And if those things were ever present, then that's a pretty good indicator that this person should not be withdrawn from alcohol at home. So they need to be medically supported for withdrawal. But that's tricky when you have somebody with dementia, because using a withdrawal management center is completely voluntary. And again, reflect on that person sitting on the bench saying, they're asking me to change, but I don't remember what you're asking me to change from. Imagine taking somebody who has got memory issues, taking them to the withdrawal management center, expecting them to stay and expecting them to understand why they're there in the first place. That's not going to happen. So at the very bottom here, you'll see a hyperlink to NiceNet. And so those of you who are healthcare professionals, there is a tool that we've developed through the National Initiative for Care of the Elderly, and it actually has some of the protocols to support medication administration for older adults, what are some of the blood work that you need to do, and also what are some of the anti-craving medications to use. So there's some considerations and ethical considerations around the person's consent. So is the person able to understand and appreciate? And if you are, if the person doesn't understand and appreciate and they don't want to stop drinking, is it and the person needs to go to long-term care, they've been deemed incapable of making the decision to go to long-term care, and so the application has gone in. Now you're sort of stuck between a rock and a hard place. The older adult has to go to long-term care, but they're not going to stop drinking voluntarily. They don't understand and appreciate. Do they have the capacity to make an informed decision? Probably not. And you have to think about the question here, and that's a really important one. What are the risks of an incompetent refusal? So if the person continues to drink, what's going to happen? They're going to have more alcohol-related falls. They're going to have an alcohol-related, fire if they're a smoker. There can be lots of risks associated with it. They could go out in the middle of the winter looking for alcohol and get lost, etc. So, and in the long-term care setting, you have to look at the individual's rights versus the rights of all of the long-term care residents. So if somebody has behavioral issues when they're drinking at home and they come into long-term care, the long-term care home is not going to be able to manage the behaviors that are related to the substance. And that's why oftentimes they will refuse to take somebody unless there's a plan for the person to be safely withdrawn or cut down on alcohol. So when you're looking at decision making around this, there's some principles to keep in mind. So there's the respect for the person, there's equity, proportionality, reciprocity, and fair process. And again, if you do this, if you need to withdraw the person from alcohol, and you do it with a slow taper, I think that's a very sort of fair and respects the person's right to continue to enjoy a beverage. It eliminates the risks for the person, to health, to further brain damage, etc. So, we need to think very carefully and thoughtfully on how to support the individual. Here's the CWA scale. I should put that earlier on in the presentation, but this is the scale that is used in the withdrawal management centers and in hospitals to determine the severity of the withdrawal from alcohol. So you can see here that people can be agitated, anxious, they can have auditory disturbances, clouding of sensorium, headache, nausea, vomiting, sweats, tactile disturbances, so they may have sort of goose flesh, tremor, and visual disturbances. So the scale goes from low to high. And as people score higher, there's more of a need for them to, more of a risk for them to have seizures and delirium. So we know that with older adults, it can actually take longer for them to withdraw from alcohol. It can take up to 2 weeks, and it's complicated by their health. And certainly because of comorbid health issues, sometimes a pre-existing dementia, and they can be at a risk for delirium. And certainly there is an increased risk for falls. So that's something that we need to be very, very mindful of. Just going to check the question here. Someone has mentioned, is there any research stating that 0% alcohol will make them crave more alcohol? Some studies link 7 to artificial sweeteners. The more sweeter you take, the more sugar you crave. I don't know about that study, but I do know that in conjunction, and I'm going to get to that probably in the next few slides, but in conjunction with a slow taper, you also would want to look at anti-craving medications. And so we'll get to that in a few minutes. But in terms of severe withdrawal for older adults, you would be really worried about them having a severe withdrawal. It can progress to delirium tremens, and that happens in about 5% of the cases. Usually occurs within 2 to 4 days after the last drink. So you're looking at delirium, hallucinations, agitations, disorientation, and confusion. And the person can be very shaky, a fast heart rate, high blood pressure, fever, and sweating. And that's a medical emergency. And there is a risk of death by 5%. So so this, if the physician is concerned about with a seizure withdrawal, or if there's a history of withdrawal seizures, they have to be managed in a supervised setting. And if sometimes the withdrawal can be managed in a if it's minor, it can be given at home, so people can be given medications to treat the withdrawal at home, but you need to have somebody responsible there to administer the medications. And again, these medications are not the same as anti-craving medications. So this is the medication that we're talking about. This is the medication that we recommend in the alcohol guidelines from the Canadian Coalition for Seniors Mental Health. It's naltrexone or Revia. It's very, very well tolerated in the older adults. There is a risk that it can cause liver enzymes to increase. But if you think about it, if the person is drinking 26 ounces of whiskey in a day, and the medication helps them to cut down to even half of that, it kind of balances it out. So there's no major liver side effects if the patient sampled alcohol, and they're only half as likely to relapse. And older adults are more likely than young people to take naltrexone regularly, and they're less likely to relapse than younger people. And when they get on the medication, there's better attendance at therapy sessions than younger patients taking naltrexone. So they seem to respond very well to a medically oriented program that's supportive and individualized. This is not something that this is for somebody that's cognitively intact. How does that work in the older adult that has dementia? Again, I can only say anecdotally, because we don't usually study older adults. We don't. There are no drug studies that would include somebody who's with cognitive impairment and actively drinking. I just anecdotally have seen that it works very well even with cognitively impaired. In fact, we have somebody just recently where the older adult had been prescribed, older adult with dementia had been prescribed naltrexone several months ago, and the family, I said, well, how much did they used to drink? Well, they used to drink, a bottle of whiskey a day. And how much are they drinking now? Well, they're just drinking this little Mickey. We get them the little plastic Mickey at the store. So they've cut down by 2/3. With no other interventions whatsoever, no insight, no counseling, just the naltrexone. And so how do we get that person to get off of the next few standard drinks in that bottle? And that's where we were using and substituting the de-alcoholized beverage and putting it into the regular bottle. So the person, for instance, may drink Weiser's Deluxe whiskey. You sub out the 1.5 standard drinks a week, and hopefully by the next couple of months, the person will be reduced to 0. So there are medications for older adults that can be used. So naltrexone is the first line. There is gabapentin, Topamax. I mean, actually, there's 11 off-label medications for craving, but the first line is certainly for older adults is naltrexone. There's one medication that the second line, a camprosate, it can cause falls in the older adults. So prescribing practices need to be sort of tailored to older adults, and you might want to start, the person may need to take it at nighttime. So if to avoid the effects of the medication and the risk for falls. Antabuse is a drug that's was used in mainstream for treatment of alcohol use disorder. It was used as a deterrent. So people, if they took it, then they got very sick. So if they took it, it would cause vomiting, sweating, and so on, palpitations. And so then if people took it and had that reaction, then they say, well, I either have to stop taking this medication and plan my binge, or I just don't drink. But we don't use an antabuse in older adults, because if they don't know that they're drinking, or sorry, that they're taking this medication, then certainly they will have a violent reaction if this is slipped in their drink. So it's not a good idea and is not recommended in older adults. But we know that antabuse, the first line naltrexone or Rivia is a really good choice for older adults. What are some of the resources that we have access to in Toronto? You can access addiction medicine through OTN, or you can go in person. You can have a case conference with regulated healthcare professionals in long-term care. You can refer people to the person to CAMH, to the Addiction Medicine Service. If you have somebody who's going to transition to long-term care, and alcohol use is an issue, and there is an active application for the person to go to long-term care, you can certainly reach out to me if you're in the Toronto Central LHIN. You don't need to a physician referral to be in touch with me. You do contact, that's the wrong email address, there's no J in front of it, but you can refer through behavioral supports at Baycrest, and they will send the information to me. For addiction medicine, it does take time. It takes a long time. So, and again, I always would get the call at 4 o'clock on a Friday night, and mom or dad is been drinking for 40 or 50 years, and all of a sudden tonight has to be the time when they quit. I'm so fed up. The family will say, I'm so fed up. I'm not buying their booze. They've called me 16 times today, and I'm not buying their booze. And what do I say to them? I said, this has been going on for 40 or 50 years. It's tonight is not the night to stop the enabling. This is not the night to the time on the weekend to precipitate withdrawal, to put your older adult parent into withdrawal and then end up in the hospital. So a very well thought out and planned a planned withdrawal and harm reduction approach needs to be considered. So it's always good to have conversations about it first, and to if the person is able to participate and understand and appreciate the reasons behind the changes, then you need to have a discussion with them as well. So there's also some resources I want to point out to you. We have monthly geriatric addiction rounds, and get those through the Brain Exchange website. That's you go to the Substance Use Collaborative, and you can see all of the OTN geriatric addiction rounds, probably dating back to 6-7 years. This is also this one here, the blood alcohol calculator. That's a really useful tool even for yourselves if you are if you're interested. What you do is you would go to the website, and it's just about being a responsible drinker. You put in your body weight, you put in the time that how many drinks you're going to have, the time that you're going to have dinner, and when you're going to go out to drive, and when you're going to come home, and how many drinks you're going to have in between. So it helps to give you a general idea, not a very firm one, but a general idea of what your blood alcohol level would be. So again, it's a really good tool to, if somebody has some insight, to demonstrate, mom or dad, you have a drink of wine with your lunch, you go to the bridge club, and you have a drink at the bridge club, and then you come home, and then you have a glass of wine with dinner, and then you go out to shopping or whatever, and this is what your blood alcohol level is. Or if you go out shopping and then afterwards you stop off and you have a drink with your friends, here's what your blood alcohol level would be. So again, it helps people to determine whether or not they're safe to drive. So the last bullet there is we have the monthly geriatric addiction rounds on the second Tuesday of the month from noon until 1 p.m. And you can put your name on that email list and contact Anna Kular at Canadian Mental Health Association. And that, again, the second Tuesday of the month, we're going to be talking about smoking cessation and the new rollout of the STOP program for long-term care next Tuesday. So, if you want to copy down that email address, or maybe Julie, you could put that in the chat box for people to grab, so they can be in touch if they want to attend geriatric addiction rounds. So there are some clinical guidelines. You can download them from the Canadian Coalition for Seniors Mental Health. And there's the NICE website that has 2 clinical guidelines, one for alcohol, one for opiates. You can click on that, and it'll take you right to those guidelines, and you can download them. And then there's, in the province of Ontario, there's Connects Ontario, and they can give people guidance on what resources are available locally to support anyone with a substance use disorder. So now it's just at 1 minute before 1:45, so we've got 15 minutes for questions, and I put that in the corner there, even the silly ones, but there are no silly questions. We want to make sure that everybody's questions are answered, and so please put them in the Q&A or the chat box, and if you can help me monitor that, Julie. So I'm going to go through.
I can pick them up for you, Marilyn. So one of the first questions is, what's the mechanism for alcohol being carcinogenic? I know you mentioned that earlier in the presentation.
What's the mechanism? Well, the toxic effect, I mean, the toxic effect of alcohol is that it does cause cancer, even more commonly breast cancer for women. Again, if you are somebody who has first generation relative that had breast cancer and you exceed the low risk drinking guidelines, your risk goes up exponentially. So that's something to sort of take into consideration, is that the carcinogenic effect of alcohol causes all those cancers. If you go to the Canadian Centre on Substance Use, so the CCSA.ca, the new guidelines are out. It's called Health Guidance on Alcohol. And it'll show you exactly how people progress in terms of risk for the different types of cancers, and by how much per standard drink per day. So, and the next question is,
So what I see here is, in your experience, does alcoholism increase aggressive behaviors, or is it more of a sedative?
well, alcohol is a drug and it's a depressant. But people drink, and it makes them feel good. But people also sort of come down from it, and it has a depressant effect. So if you drink too much, then you eventually fall asleep or you pass out. Some people, and there's an expression, they have the Constitution of Churchill, because Churchill used to drink 40 ounces of scotch a day, if I'm not mistaken. Some people are more tolerant. Some people may have a predisposition. There may be existing mental health issues, which, when you add alcohol on top of that, can trigger other behaviors. And some people, for instance, who have PTSD, so post-traumatic stress disorder, you add alcohol to that, and it may trigger feelings of, they may feel good at the very beginning, but they may be the person that starts the fight in the bar. So there is a correlation. So
Sorry, go ahead.
yeah, go ahead.
So just a comment, I know you're speaking about non-alcoholic beverages. So just a comment, someone's partner has been abusing alcohol for many years, sober now for 5 years, and has been drinking non-alcoholic beers. This route has been very successful, and that there's even crafted non-alcoholic beers. So that was just a
Yeah,
comment.
I'm so glad to hear that. I'm really glad to hear you, and thank you for sharing that. Because in my experience, again, with people who have dementia, the variety now compared to 5-6 years ago, and on the type of dealcoholized beverage, has really been quite remarkable. And some of them you really can't tell the difference.
Earlier question, are the slides available for resource links? So there will be a recording available, and the slides for those will also be up there. So again, I would refer you to check back to the Alzheimer's Society of Toronto's YouTube channel for that. Another question here, what does OTN stand for? There is a participant coming from BC, so looking
Okay.
for some clarification.
OTN, so that's Ontario Telemedicine Network. So that's the platform that we use for secure appointments. And it's used by medical and healthcare professionals in Ontario. I think you have a similar platform. It's more secure than Zoom. We don't typically use Zoom for clinical purposes.
Okay. Next question is, long-term care often won't take people with any addictions, whether it's alcohol or smoking. How could we help people get into long-term care when they don't want to accept such individuals?
Yeah, well, I mean, each home has the right to refuse if they feel that they can't manage their care. So that's why I really focused a lot on how to do a slow taper with somebody who has dementia, because you want to make sure that all the behaviors that are associated and the risks of the withdrawal piece, that they don't happen when the person sets toe in the long-term care home. You don't want to start, you send the person to long-term care if they're drinking 10 or 5 standard drinks a day, and then they go to a long-term care home and they get nothing because the policy is that we don't give any alcohol unless it's ordered by the doctor. So it's all about having a careful and compassionate approach to withdrawing the person from alcohol safely, compassionately, and making sure that you're eliminating the risks. And usually, the application that goes into long-term care, there's a section